Good morning, everyone. Today we will see about eye. In that, here you can see that the anatomy from anatomy and physiology only one questions are asked. That too once or twice. So we will skip these parts and we will directly go to the errors of refraction. But before that, we'll briefly see what the anatomy of the eye. If you see, eye is a ball which is made up of three layers. From outside to inside, you have sclera, and inside that you have choroid or vascular layer, and then the third layer, which is an incomplete layer, which is the retina. The sclera is not a complete ball. Anteriorly, the sclera is deficient where retina takes its place. Sorry, cornea takes its place. The vascular part, based on where it is given different names. If it is posteriorly and it is made up of full blood vessels, it is called as choroid. Here, near the lens, it forms the uh, here you can see the anatomy of eye. This is the sclera. This is the choroid or vascular layer. Anteriorly, it forms the ciliary body, ciliary processes. And inside, you have retina. The retina ends till here. The end of retina, it is called as ora serrata. Eye is divided into two segments, anterior segment and posterior segment. The anterior segment is anterior to the lens capsule. The posterior segment is posterior to it. The anterior segment is again divided into two chambers, anterior chamber and posterior chamber. It is divided with the help of the iris. The part which is between the posterior surface of cornea and the iris, this is called as anterior chamber. And the part which is between the iris posterior to the iris and in front of the lens, this is called as the posterior chamber. The importance of these structures you will understand later when we go on discussing. Now for the refractive errors. Our eye is like a lens. Whenever the light rays fall, whenever the light rays enter our eye, the eye has the power to converge those light rays and it converges it on the retina. If the light rays are properly converged or it is focused on the retina, you get a clear image. Otherwise, you get a blurry image if it is not focused on the retina. Now, if there are any problems in this refraction, so when the light comes, it gets refracted at cornea and then at the lens, and then it gets focused with the retina. If there are any problems with refraction at the cornea or refraction at the lens, we call it as refractive errors. And refractive errors are also called as ametropia. A normal eye is also called as eumetropic eye. Okay. This ametropia can be uniocular and binocular. In uniocular ametropia, you have spherical errors and you have cylindrical errors. What are these? We'll see one by one. And in binocular, the pathology is of both eyes. Means the both eyes have the pathology. Each eye can have different pathologies like myopia or hypermetropia. Before going into each topic in detail, we will see about power of a lens. For example, we will take a lens. This is a normal refractory media. And we will take a screen. Now we will fix this lens in this position A, and we will fix this screen at this position B. What is the power of this lens? In simple words, what is the power? Power means the ability of the lens to converge the light rays. The power of this lens is that it can converge the light rays coming from here on this point. Now we will change some variables and see what happens to the power. Now if I increase the curvature of this lens, as I show it in second scenario, if I increase the curvature of this lens, the power of the lens has increased. It is focusing light rays in front of the screen, that is retina. This is the screen. Third scenario, in this, we will fix the lens, we will fix the screen, but we will increase the refractive index of the lens. When we increase the refractive index of the lens, again, the power of the lens is increased and it will focus the light in front of the screen. Now, the third point. The third point is that you move the screen away from the lens. Now the lens will focus the coming light at the same point it was focusing before, but it is not reaching the screen. So we can say that the lens power is decreased, but it is not actually decreased. Relatively it is decreased because the screen has moved away. So there are three scenarios that I gave. There is a lens, there is a, what is the, you understood how the power varies with varying different aspects of the lens. If you increase the curvature of the lens, the power of the lens is increased. If you increase the refractive index of the lens, the power of the lens is increased. If you move the screen far away, you could say that the power of the lens is increased because it is focusing light in front of the screen. Now, we will see each of these diseases individually. I said the refractive errors are divided into spherical and cylindrical. Under spherical errors, there is myopia and there is hypermetropia. We'll see what is myopia and what is hypermetropia. First, we will deal with hypermetropia. What is hypermetropia? Hypermetropia is a refractive error in which the incident parallel rays, the light rays which are coming from the infinity, are brought to focus posterior to the retina. Incident parallel rays are brought to focus posterior to the retina when accommodation is at rest. This is very important that you keep your accommodation at rest. And how do you do that? I will tell you afterwards. So in simple words, I can tell that the refractive power of the eye is reduced, right? Because the refractive power of the eye is reduced, it is not able to focus it on the retina. It is focusing behind the retina. In simple words, hypermetropia is decrease in the refractive power of the eye. What are the causes for this? The causes for this are very intuitive. If you know the what are the things which affect the power of the lens, you can obviously say this. When can the power of the refractive media decrease? When you decrease the curvature of the refractive media. If the curvature of the cornea is like this, if you decrease it and make it plain, then the refractive power is decreased. Same is with the lens. If you decrease the curvature of the lens, it will decrease the power of the lens, thereby causing hypermetropia. For example, this is seen in cornea plana and lens plana. Another scenario, other cause, that is you decrease the refractive index of the lens. If you decrease the refractive index of the lens, the power of the lens is decreased, and thereby again you will have hypermetropia. And then the third point, the size of the eye. If you decrease the size of the eye, the screen has moved forward. So the lens is focusing the light rays behind the screen. Again, you have got hypermetropia. And then if there is displacement of the lens, if this lens gets displaced, then also you can get hypermetropia. So if I briefly summarize it, what is hypermetropia? Hypermetropia is decrease in the power of the eye, or the light rays which are entering into the eye are focused behind the retina. The causes for which, for decrease in the power of the eye, are due to decrease the curvature of the refractive media, that is cornea and the lens, cornea plana, lens plana. You decrease the refractive index, you decrease the size of the eye, you move the screen forward, that is nanophthalmos, or you displace the lens forward in cornea, in lens displacement. These are the causes for hypermetropia. Why did I say that accommodation should be at rest? This is because if the accommodation is not at rest, the eye will the eye will try to overcome your this refractive error by contracting its ciliary muscles, thereby increasing the power of the lens. That's why while checking for hypermetropia in these patients, you need to use a cycloplegic like atropine, which will paralyze these muscles, and thereby you get a proper power for that patients. Next, we'll move on to types of hypermetropia. There is latent and there is manifest. Latent is when the patient has hypermetropia, but his accommodation power, his accommodation power is overcoming this hypermetropia. So the patient is able to read the near objects, he is able to read it clearly, but he has pain while doing this. He has power defect, but it is not manifesting. It is overcome by accommodation. For these kind of patients also, when you are checking for refractive errors, you need to use cycloplegics like atropine. And there is manifest hypermetropia. In manifest hypermetropia, there is hypermetropia. The patient complains that he cannot see the near objects. In this also, a part of it is overcome by the accommodation reflex, and a part of it is not overcome by the accommodation reflex. Talking about types of hypermetropia, there is latent hypermetropia and manifest hypermetropia. Latent hypermetropia is the patient has problem, but because of his accommodation, it is not manifesting. It is not aberrantly seen. But if you use a cycloplegic like atropine and check for his refraction, then you will get to know that he is hypermetropic. This accommodation can maximally contribute for plus. This accommodation can maximally contribute for plus 1 diopter power, not more than that. If his power, if his spherical power or refractive error is more than plus 1 diopter, it will manifest. That is, he will have problem while reading the things. That is called as manifest squint. So inside the manifest squint, the plus 1 diopter initially it is like taken over by uh, accommodation, right? So that is not seen. Only the absolute, only the thing which is not, the eye which is not able to accommodate is being seen. That is called as manifest squint. So there is absolute hypermetropia, which is equal to manifest hypermetropia plus latent hypermetropia. Did you understand? This facultative hypermetropia is nothing but the latent hypermetropia itself. When the power increases too much and the eye is unable to accommodate that power, then you will have manifestation. This manifestation plus the latent squint, latent hypermetropia, it is the absolute power of the eye. Did you understand? And next, we'll see
So
the
what you are telling is in in manifest hypermetropia, you are telling that the facultative hypermetropia is nothing but the latent hypermetropia which has manifested now. Am I correct? Is my understanding correct?
no, bro. Look, there are two
Please
types:
explain. Yes.
latent and manifest. In case of latent, the person has a problem, but it is taken care by his accommodation reflex. In case of manifest, the patient has a problem. This problem has two components. His power is more than 1 diopter. So till 1 diopter, his eye accommodation will take care of 1 diopter power. If it is more than 1 diopter, say it is 3 diopter. Now this plus 2 diopter is what is not being taken care of. So this plus 2 diopter, when you do his refractive error check, when you check his refractive error without putting cycloplegia, you will see that he has plus 2 diopter. Does he actually has plus 2? No, he has plus 3. How do you get to know this? If you do atropine, if you put atropine, you will get to know that he has plus 3 diopter refractive error. The absolute hypermetropia is this plus 3. Manifest is plus 2. Did you understand?
Okay, understood now. So the facultative manifest hypermetropia is +2 and absolute hypermetropia is +3.
Plus 3.
Is it correct now?
Yeah.
Yeah, thank you for your explanation. Continue.
Next, we will see the clinical features of hypermetropia. In clinical features, symptoms. Because this symptoms can be classified as symptoms because of refractive error, symptoms because of the accommodation of that refractive error. Symptoms because of refractive error, obviously the person will have a blurred vision, and then symptoms because of accommodation. His ciliary muscles are constantly contracting, because of which the patient will have asthenopic symptoms. What are asthenopic symptoms? Because of the refractive error, his eyes tries to balance this refractive error, because of which he will have pain in the eyes, headache, and all those things. These are common experiences which will be experienced by those who are wearing spectacles. And because his accommodation reflex is acting too much, it will cause a convergent squint. That is, his both eyes moves towards his nose. You will see that he has a convergent squint. If it go this, and then, did you understand? Symptoms because of refractive error, symptoms because of accommodation, excessive accommodation. Because of refraction, the patient will have blurred vision. Because of too much of accommodation, the patient will have asthenopic symptoms. That is, he will have eye pain, head pain, and all. And because the accommodation is taking place too much, that's why the person's eyeballs will move towards his nose. You will see that the person will appear as if he has squint. That is esotropia, convergent squint. Now, what are the signs? Signs, we have already seen that hypermetropia is seen in a person who is having small eye. So you will see small eye, small cornea, small anterior chamber. On ophthalmoscopy, the eye is small. The eye is small, this much only. The retina, the nerve fibers from the retina form a bundle and go out. This is called as optic disc. Now, this optic disc is large in comparison to the fundus. So this will appear as bulging. So you will see in ophthalmoscopy pseudopapillitis. That is, the papilla is normal. That is, the optic disc is normal. Even though the optic disc is normal, because the fundus is small in comparison to the optic disc appear comparatively large. So you will see pseudopapillitis. And because the fundus is small and everything is congested, you will see silk short retina. That is, the retina will appear shiny. The retina will appear shiny. And because the blood vessels are all congested here, you will see undue tortuosity and abnormal branching here on ophthalmoscopy. This is the fundoscopic or ophthalmoscopic picture what you will see. That is, this is the papilla which should have appeared normal, but it appear enlarged because the fundus is small in comparison to the optic disc. And then the retina appears shiny, and you can see that the blood vessels appear tortuous. These are all relative findings. The fundus is actually normal, but because the eyeball is small, you see all these findings. So again, clinical features, symptoms because of refraction, that is blurred vision, and symptoms because of accommodation. Because of excessive accommodation, he has pain in the eye, headache. These are called as asthenopic symptoms. And because of excess of accommodation, he has a convergent squint. That is, his eye, both eyeballs moves towards the nose. And then signs, external signs and ophthalmoscopic signs. External signs, this hypermetropia is seen in patients who have small eye. So you will have a small eyeball, the patient will have a small cornea, the patient will have a small shallow anterior chamber because small eyeball. And then you have the ophthalmic sign, because the eye is small, the optic disc appears large, pseudopapillitis, silk short retina, and undue tortuosity or abnormal branching of the blood vessels on the retina. This is what you see. Management, till here, did you understand? This is the causes, the pathology, how it is occurring, and then the types,
So,
then the clinical features.
pseudopapillitis एक बार.
Pseudopapillitis. Okay.
Hmm.
Now, inside the eyeball, when you see, when you put a retinoscope or ophthalmoscope and see, this is the fundus which you are seeing. That this is the retina which you are seeing. In the retina, you have this optic disc and you have a macula. Okay. This optic disc is nothing but collection of the nerve bundles. nerve fibers, collection of the nerve fibers which are coming from all these things. Now, when this eyeball is small, okay, I will make it more smaller. When this eyeball is small, the nerve fibers remain the same number, but eyeball has become small. So this bundle will appear large. This bundle will appear large. This is what we are calling as pseudopapillitis. Pseudopapillitis. Why are we calling as pseudopapillitis? Means in case of papillitis, the optic disc head or this optic disc will appear enlarged. That's why we are calling it as pseudopapillitis. There is no papillitis in this patient. Actually, everything is normal, but it is enlarged because the eyeball is small in comparison to the optic disc. Say clear, huh?
Clear. Clear one.
Now, for management of hypermetropia, in this management investigation, there is no such investigation. Just you need to do refractive error checking. In that, if refractive error checking, always remember you need to use a cycloplegic, because you know that in hypermetropia, accommodation is trying to balance out the refractive error. That's why you need to use atropine, which is a cycloplegic. Afterwards, you check for the refractive, what is the refractive error, and then you can prescribe. Later we'll see what that is. Now, management, treatment. In case of treatment, you have optical treatment and surgical treatment. Surgical treatment, you don't do it, there is no much options. In case of hypermetropia, there are more options in myopia. In optical treatment, we'll see. Now you understood that the hypermetropia is a problem where the power of the lens is less. So all your treatment should be aimed at increasing the power of eye. That is increasing the problem is decrease in power. So all your treatment should be aimed at increasing the power of the eye. In this, there are different ways you can increase the power of the eye by using plus lenses. The plus lenses are nothing but convex lenses. Use convex lens, you increase the power of the eye. This is a optical way how you can correct hypermetropia. And surgical problem and surgical method. In this surgical method, you can use intraocular lens. Intraocular lens, these are high power intraocular lens. This is feasible in a patient who is more than 40 years. You don't do it in small boys or 20-30 year patient. You do it in patients who are more than 40 years, or patient who doesn't have a lens inside his eye, aphakia. There you can use an intraocular lens with appropriate power. The newer modalities are thermal keratoplasty and hyperopic. What do we do here? This is the cornea. We burn the sides of the cornea. We will remove the sides of the cornea. This causes increase in the thickness of the in middle. It causes increased thickness in the middle of the cornea. This again increases the power of the cornea, because increase in the curvature also increases the power of cornea. So from start, we'll see hypermetropia is a problem of decrease in the power of eye, because of which the parallel rays are getting focused behind the retina. Now, this should be checked when accommodation is at rest. The causes for which are small eye. Small eye, again, the light rays will get focused behind the retina, hypermetropia. Curvature. When the curvature is plane, when you decrease the curvature, again, you will develop hypermetropia. When you decrease the refractive index, you will develop hypermetropia. If the lens gets displaced anteriorly, again, you will get hypermetropia. Sorry, if it get displaced posteriorly, you will get hypermetropia. And then types. There are two types, latent and manifest. Latent is the patient has hypermetropia, but his accommodation reflex is taking care of it. So he is not presenting to you with the problem of blurred vision. He may present to you with problems of asthenopia, that is eye pain and headache. And there is manifest. Here the patient will present to you with eye pain, headache. Along with that, he will present to you with blurring of vision. Next, we saw the clinical features. Under clinical features, symptoms and signs. Symptoms, Because of the refractive error, the patient will have blurred vision. Because of the accommodation, the patient will have headache, eye pain, which are nothing but the asthenopic symptoms. Because of too much accommodation, the patient can have convergent squint. That is, his both eyes move towards his nose. And then we saw the signs. This hypermetropia is seen in a patient who has small eyes. So the patient will have a small eyeball, because of which he will have a small cornea, and then he will have a shallow anterior chamber. When you do ophthalmoscopic examination, you will see pseudopapillitis, silk short retina, and undue tortuosity of and abnormal branching. Management, you investigation, you again refractive error correction, and treatment is optical and surgical. Optical, you increase the refractive power by giving convex lenses. Surgical, you can use intraocular lenses, or you can do thermal keratoplasty or hyperopic LASIK. This completes hypermetropia. Is there any doubt?
No.
No, so the explanation is really good. We are all understanding the concepts clearly. You can proceed on to next myopia if anyone doesn't has doubt.
Okay. If nobody has doubt, we'll proceed to myopia. Okay. Myopia is opposite of hypermetropia. We saw that in hypermetropia, there is decrease in the power of the lens or decrease in the power of eye. Here in myopia, there is increase in the power of eye, increased power of eye, refractive power of eye, because of which the light rays which enter are getting converged in front of the retina. So the light rays which are coming are getting focused in front of the retina when accommodation is at rest. The causes for which, again, you can only uh, make it out what are the causes for which if you have listened to the initial explanation on how power is affected by different aspects. If you want to increase the power of the eye, myopia is nothing but there is increase in the power of eye. If you want to increase the power of eye, how can all what are the various ways you can increase the power of the eye? You can increase the curvature of cornea, or you can increase the curvature of lens. This is seen in keratoconus. This is seen in uh, conus, deformity of lens, lenticonus. The curvature has increased, so the power of the eye has increased, because of which you are getting myopia. Or you can see this in increased refractive index. The power of the eye you can increase by increasing the refractive index, which you can see in cataract. Position. If the lens get displaced anteriorly, it will focus the light before it reaches the retina. That way also it can produce myopia. And then axial length. If you move the screen away from the lens, again the lens will not be able to focus the light on the screen, that is the retina. Again you will develop myopia. So myopia is a problem of increased power of eye. The refractive power of eye is increased. So there are different mechanisms how the refractive power of eye can be increased. The causes can be increased curvature of cornea, or increased curvature of the lens, or increased refractive index of this lens, or the eyeball size has increased, or the lens has displaced anteriorly. These are the different causes. And then types. The types are very simple. It is divided into simple myopia and pathological myopia. Simple myopia, most of us do have simple myopia. If it is less than minus 6 diopter power, we call it as simple myopia. If it is more than 6 diopter, we call it as high myopia or pathological or degenerative or progressive myopia. In this, the pathological myopia is the dangerous one. And why it is dangerous, we will see. Next, we'll go on to the clinical features. Again, clinical features, symptoms and signs. How will the patient present to you with? The patient will present to you with refractive errors. What will be the refractive errors? The patient will complain of is not able to see the far objects. So there is blurred vision. And because he is not able to see the far objects, he tries to compensate it, because of which he has eye strain, eye pain, headache, and all those things. Now the power has increased, so the accommodation fails. the accommodation fails. The accommodation does not come into action only. So the person will have exophoria, that is his eyes move outside, that is temporarily. In hypermetropia, the accommodation was overacting, that's why his eyes were moving towards the nose. But here, the eyes will move outside. So the patient's eyes will appear as exophoria. Next, we said that myopia is a problem of increased power of the eye. This increased power of the eye can be caused by increase in the size of the eyeball. Now, all the signs that you see are because of this increased size of the eyeball. Signs, you can see a large eye on ophthalmoscopy because this eye is large. See, because this eye is large, this increasing size of the eye will stretch all the three layers of the eyeball that we have already discussed, that is choroid, sclera, and the retina. This will produce various signs. Because of the increased size of the eye and stretching, there are various signs which are seen. On ophthalmoscopy, if the retina gets stretched, here you can see, if the retina gets stretched, the retina will break. The retina will break and it will get atrophied. So you will get a tessellated or tigroid appearance. What is this? We'll see. You have this eye which is expanding, because of which the retina is getting teared. The retina is getting teared and the choroid is being visible. So you will see some areas there is retinal pigment epithelium, some areas there is atrophy, and some areas appear where will show choroid. So this will appear like a tabby cat or tigroid appearance. Here you can see this. This is how the retina will appear in a high myopia or pathological myopia. Because of the increased size and increased stretching of the retina, there are breaks and the choroid gets visible. Because of this, you will see this appearance. And when the choroid gets stretched, the choroid also gets atrophied. And when the choroid gets atrophied, you will see a temporal myopic crescent. Here you can see a temporal myopic crescent. This is the temporal myopic crescent. This is because the choroid is also getting stretched. When the choroid gets stretched, it also gets atrophied. And this white part which you are seeing, this is sclera. The white thing which you are seeing here, that is the sclera. And then the sclera can also get stretched. When the sclera gets stretched, it becomes weak. So you can develop posterior staphyloma, that is bulging of the sclera. Okay, now we'll see one by one again the clinical features. The clinical features are divided into symptoms and signs. The symptoms, because of refractive error, you can have eye pain, blurred vision. And because of compensation, you can have exophoria. Now, signs. Because the eye is very large, it is stretching all the layers of the eye. If the retina gets stretched, the retina will get atrophied and you will have a tessellated tigroid appearance. And when the choroid gets stretched, the choroid gets atrophied, and behind the choroid you have sclera. The sclera is seen, and here you get a sign which is called as temporal myopic crescent. Temporal myopic crescent. And when the sclera gets stretched, the sclera breaks, and because of which you will see a posterior staphyloma. Now understand, choroid has this is retina, and this is, if this is retina, this is choroid. In between retina and choroid, there is another membrane which is called as Bruch's membrane. And because of this stretching, this Bruch's membrane can also break. If this Bruch's membrane breaks, you will see lacquer marks. These are the lacquer marks which you are seeing. These are the lacquer marks. This is because of stretching and breaking of Bruch's membrane. Next, we'll see the management.
South, 1 minute. South,
Hi,
can you explain explain us little bit more about Bruch's membrane?
Bruch's membrane. Okay. Now, this will again be, we'll see this again in retina. So I said the eyeball has three layers from outside to inside, that is sclera, choroid, and retina. Between the retina and the choroid, you have Brooks membrane. This is nothing but a part of Brooks membrane only. Innermost layer of choroid is nothing but Brooks membrane. What does it Brooks membrane do? The Brooks membrane helps in diffusing substances from choroid to the retina, and it helps in removing the substances from or waste products from retina to the choroid. That is the function of Brooks membrane. It is nothing but the innermost part of choroid itself. And when the eyeball gets stretched, it also breaks, because of which you will see these lacquer marks. Did you understand?
Yes, perfect, Rahul. We understood.
Okay. Next, the management. The management is investigation and treatment. Investigation is again refractive. You check for the refractive errors by giving cycloplegics. And treatment. Here, myopia is a power of increased. Myopia is a problem of increased power of the eye. So your treatment should be aimed at decreasing the power of eye. In this, you can use optics. How can you decrease the power of the eye? By using concave lens or negative lenses. And then you have surgical correction. In surgical correction, you can use laser or you can use other non-laser modalities. Now, I said that if you increase the curvature of the cornea or the lens, you increase the power of the lens. What can you do? If you flatten this cornea, or you can, if you decrease the curvature of the cornea, you can decrease the power of the lens. So previously what they used to do was, this was the cornea, right? They used to give radial cuts on the cornea. When these radial cuts were given, and when these radial cuts were given and they were left, these radial cuts would heal by fibrosis, and when these would heal, these would stretch, or these would pull the adjacent cornea. When these stretch, this pull and stretch the cornea, this would cause the flattening of the cornea. So radial keratotomy was used as a method of correction of myopia. It helps in decreasing the refractive power by decreasing the curvature of the lens. There is another one mechanism how you can decrease the curvature of the lens, that is by using intracorneal rings. You place these intracorneal rings inside the stroma of you place these intracorneal rings inside the stroma of this cornea. This will again pull the cornea, and this will again cause flattening of the cornea, thereby again decreasing the curvature of cornea, and then decreasing the power of eye. If the person has very high myopia, very means very high myopia, more than 21 diopter, minus 21 diopter myopia, at that time you can remove his lens itself. If you remove the lens, the refractive medium is itself removed, and thereby you can correct his myopia. The latest techniques which are used are laser techniques. In this, you have LASIK. What LASIK, SMILE, and then LASIK. These are the various laser modalities which are used. LASIK is nothing but you are using laser to correct myopia. In this, what you do, this is the patient's eye. This is the patient's eye. This is the cornea. So in this, you cut the cornea on one side and you lift a flap like this, the flap that you have raised. And then you use a argon laser and you burn the stroma of the cornea. If you burn the stroma of the cornea, the thickness of the cornea is reduced. When the thickness of the cornea is reduced, the power of the cornea is reduced. And thereby, and you again reposition this flap and suture it. This is the modality of treatment of myopia. You understand? LASIK. LASIK full form, the full form of LASIK is laser assisted in situ keratomileusis. Keratomileusis. Here, what you do is you use laser to burn the cornea to decrease its thickness, thereby decreasing the refractive power of the cornea. And another one technique is SMILE technique. where in the cornea you remove a part of the cornea, you give an incision and you remove a part of a lenticule, cuboid shaped part of a cornea, and again you decrease the thickness of the cornea, and thereby again you will get decrease in the refractive power. This is how you can treat myopia. So in brief, so if I brief out everything again, so myopia is a problem where there is increased power of eye. The power of eye has increased. How can the power of the eye increase? If you increase the axial length, the power of the eye is increased. Curvature increase, index increase of the position is moved anteriorly, displacement, anterior displacement. All these are the causes for myopia. Then there are types: simple and pathological. Simple, less than 6 diopter, minus 6 diopter. Pathological, more than minus 6 diopter. Clinical features. Clinical features, symptoms and signs. Symptoms: the patient can have a blurred vision, stress on the eye, he can have exophoria. And signs, there are various signs. First, you will see that his eye is very large from outside, and then the ophthalmic signs, because of stretching of each of the layer. When the retina gets stretched, you will get a tessellated or tigroid appearance. When the choroid gets stretched, you will see temporal myopic crescent. When Brooks membrane gets stretched, you will see lacquer marks. When the sclera gets stretched, you will see posterior staphyloma. Now, this stretching not only affects the outer parts, that is the coverings of the eyeball, it also affects the vitreous which is present inside. When it stretches the vitreous is like a gel. When you stretch the vitreous, it liquefies, and this will appear as floaters to the patient. He can also complain of floaters, that is, some particles are floating in front of his eyes. It is because of stretching, man. You remember, there is increase in power, there is increase in the size of the eyeball. This stretches all the layers, and these are the signs which you see because of the stretching. And then treatment is always aimed at decreasing the power of the eye. You can decrease the power of the eye using optics or surgery. By using optics, you can use negative lenses to decrease the power, or surgery, non-laser or laser method. In this, radial keratotomy, intracorneal ring, lens extraction. Using laser, LASIK, SMILE, that is small incision lenticular extraction, or LASIK can be used. Does anybody have any doubt?
भाई फ्लोटर्स क्यों?
Floaters, uh, this is the eye. Eye has vitreous here. When the eye enlarges, it stretches the vitreous also. The vitreous will liquefy. Okay, this will liquefy. And these water molecules are free inside the gel. So now, whenever the light falls, these water molecules will cast shadow on the retina. That's why you see floaters. These floaters, when you move your head, these water molecules will move in the opposite direction. So you see that these particles are moving in the air. That is called as floaters. Astigmatism. Here you can see that we have covered most of the questions. Most of the questions are about hypermetropia or myopia, and we have seen the classification, that is ametropia we have seen. So we will see this thing, that is astigmatism, and then we will see what is accommodation and then presbyopia, and we'll end it there. Astigmatism. This is astigmatism. Now, the definition of the astigmatism, it is a type of refractive error in which the incident parallel rays do not come to a point of focus on the retina due to refraction varies in different meridians. You have this, your cornea is like this, right? On the sagittal, if you take a coronal section, your cornea is like this. It has two diameters, a longitudinal diameter and a horizontal diameter. Actually, it is not like this. If you take a sagittal section, your cornea is like this. It is bulging. So if I draw it properly, this vertical meridian will be more like this, and this horizontal meridian will be more like this, and these are at 90 degrees to each other. So if I take a cross section and show you, when the light falls, this vertical meridian will focus the light on the retina. This horizontal meridian, which is like this, will also focus the light on retina. If these two meridians do not focus the light at the same point, then you will develop astigmatism. That is what the definition is saying. It is a refractive error in which the rays which are incident do not come to a point on focus because of different refractions at the two meridians. This different refraction. That is called as astigmatism. Then you have types of astigmatism. There is regular type and there is irregular type. I told that there are two meridians, that is vertical and a horizontal. They are always 90° to each other. In a regular astigmatism, they will be at 90° to each other. But the problem is, one of them will be more curved. In regular astigmatism, the two meridians are at 90°, under which you have with the rule astigmatism. With the rule astigmatism means the vertical meridian is more curved in comparison to the horizontal meridian, but they are at 90° to each other. Against the rule astigmatism means the horizontal meridian is more curved in comparison to the vertical meridian. In oblique, the meridians are at 90° to each other, but they are not like this. Rather, they are like this. The vertical meridian is not at 90°, it has moved to some other place, and the horizontal meridian is again 90° to it, but it is not in the vertical and horizontal plane as we saw before. Why do we call this as with the rule astigmatism? Normally, your eye is like this, and you have eyelids. Now, this eyelids put pressure on your eye, because of which the cornea bulges slightly anteriorly. So your vertical meridian is always slightly more than your horizontal meridian. It is slightly more. When this becomes exaggerated and becomes very high, it is called as with the rule astigmatism. That is, it is with the rule only, but it is more. The vertical meridian is more. Against the rule is the horizontal meridian becomes more curved. And oblique is the meridians are at 90° to each other, but they are not at the original sides. And there is irregular astigmatism. In irregular astigmatism, the vertical and horizontal meridians are not perpendicular to each other. They are not at specific angles, so they are haphazardly placed. This you can see in scarring of cornea. Then you can these are the types. This is how you can divide the astigmatism. You can divide the astigmatism based on type of refractive error they produce. That is, you have two axes, right? If the curvature of the one axis becomes too much, then it will become myopia, and the other can remain as it is. That is, axis 1 is emmetropic, axis 2 has become myopic. This is called as simple myopia. If both of them become myopic, you can call it as compound myopia. If one of them becomes hypermetropic, you call it a simple hypermetropic astigmatism. If both of them become hypermetropic, you call it as compound hypermetropic astigmatism. Mixed astigmatism is where one becomes myopic, the other becomes hypermetropic. That is, the refractive errors are different in the two planes, that is in the vertical meridian and the horizontal meridian. The clinical features are exactly the same that we have discussed before. That is, the patient has blurring of vision, the patient has pain in the eyes, the patient has headache. All those symptoms the patient has. When you see the patient, he will tilt his head. This is because his meridians are not in a proper plane. So if his meridians are not in a proper plane, he tilts his head so that his meridians come in a proper plane. That's why he tilts his head. That is also a sign. Then the management of astigmatism. For managing astigmatism, you need to know the curvature of the lens. To know the curvature of the cornea. To know the curvature of the cornea, you can use keratometry. Keratometry This is a technique where you can assess the curvature of the lens, or you can use a Placido disc. In Placido disc, there is a disc having alternative light and dark bands. You place it in front of the patient's cornea. You will see the reflection. If the meridians are if the meridians are too much curved and all, then you will see that these rings are distorted. These rings are distorted. This is also investigation which is used. There are other investigations. Just remember the names. That is astigmatic fan, astigmatic disc, and also you can do retinoscopy. And based on the defect, most of the time the retinoscopy, the fundus is normal in case of astigmatism. Now, the treatment. Again, the treatment is optical and surgical. Optical, you use lenses. Cylindrical lenses. These cylindrical lenses are called as toric lenses. Toric lenses. You can use spectacle lens, contact lens, or cylindrical lens. In surgical correction, again, whatever the defect it is there, you need to correct it. If the vertical meridian is too much curved, you see this. If the vertical meridian is too much curved, that is, it is creating myopia. So you can give incisions, radial keratotomy incisions here, and thereby you can stretch the cornea in this plane and bring it more. You can make it more straighter, less curve. That is, you correct the refractive errors. The refractive error correction, what we have talked for myopia and hypermetropia, same refractive error surgeries you can do for astigmatism for correction of the problems. That is, you can use laser, and you can do LASIK for correction of astigmatism. That is correction of the increased curvature, or you can use photo radio keratotomy. So once again, we'll see what is astigmatism. Astigmatism is a problem where the light which is falling on the two meridian is not getting focused at the same point. So the different types, you have two types, regular and irregular. Regular means always the vertical meridian and horizontal meridian are 90 degrees to each other. This can be with the rule, that is, the vertical meridian is more curved comparison in compared to the horizontal meridian, or it can be against the rule, where the horizontal meridian is more curved in comparison to the vertical meridian. Oblique, the meridians are not at their usual sides. Irregular means they are not at specific angles to each other, that is, they are not at 90 degrees. And based on the refractive errors, you can divide them as simple myopic, compound myopic, simple hypermetropic, compound hypermetropic, and mixed astigmatism. Clinical features: as with any other refractive errors, this patient has blurring of vision, headache, eye pain, and all those things, asthenopic symptoms. Signs: the patient will have head tilt, and the patient will have difficulty in reading the letters. He will say that the letters are running together. Because of the defect, he says that the letters are running together. That is, the ending of the letters appear to be, these letters appear to merge to him. That is called as, that is also seen in these patients. Management, again, investigation. For investigation, you need to see the curvature of the cornea. For that, you see keratometry, Placido disc. There are other specific investigations in case of astigmatism. There is astigmatic fan, astigmatic disc, and retinoscopy. This you do for all refractive errors, but here you do not get any specific signs such. And then treatment, you can treat it optically and surgically. Optically, you treat it by giving cylindrical lenses, and in surgically, you do the same surgeries what you did for myopia and hypermetropia for the specific defect. The which meridian is causing which defect, you do specific surgeries for them, like LASIK and photoradio keratotomy. This is about astigmatism. Did you guys understand? Does anybody have any doubt?
No doubt, sir.
No doubts.
रिगार्डिंग तो दो मेरिडियन आईबॉल को रेफर कर को कि लेंस को रेफर कर को
ये मेरिडियन आर विथ रेस्पेक्ट टू कॉर्निया.
कॉर्निया ओके.
कॉर्निया, दे आर नथिंग बट वर्टिकल एंड हॉरिजॉन्टल डायमीटर्स करके याद रख लो.
हाँ, वो पैरेलल लाइट रेस जो आते हैं ना, उसे क्या राइट
नहीं
राइट
उसे
रेस को
रेफर
रेफर
कर,
करो।
नहीं लाइट रेस को रेफर कर को नहीं, कॉर्निया को रेफर कर को बोल रहा हूँ
ओके
विथ रेस्पेक्ट टू कॉर्निया होंदे.
यस यस
Now we will see a short topic, that is accommodation. What is accommodation? It is the ability of the eye to see the near objects. It is the ability of the eye to see the near object. How does it takes place? Accommodation, it is made possible because of contraction of ciliary muscles. Ciliary muscles. Now, first, let us see. To see a near object, you need to increase the power of your eye. Power of your eye. And to increase the power of your eye, you can't do much, but you can change the anterior curvature of the lens. If you increase the anterior curvature of the lens, the refractive power of the eye will increase. This happens when ciliary muscles contract. So when you want to see a near object, you want more power in your eye. This is made possible because of your ciliary muscles contraction. When your ciliary muscles contract, your zonules become loose and this anterior curvature increases. The anterior curvature increases. And then your eyes move towards your nose to see the near object, and then your pupils constrict. These are the three components of accommodation. What is accommodation? Accommodation is ability of the eye to see near objects. How is it made? What are the components of accommodation? The components of accommodation are uh, increased anterior curvature of the cornea, increased anterior curvature of the lens, and then convergence of the eyeball, and then constriction of the pupil. These are the three components of accommodation. Now, based on this, you have a problem. When the person is aging, his ciliary muscles become weak. So he has difficulty in seeing nearby objects. That is called as presbyopia. Myopia. His ciliary muscles are weak, so he is unable to read the object. This is called as presbyopia. Now, there is presbyopia is physiological and occurs in everyone. So you need to know the lens that you prescribe for them. The power of the eye is decreasing. Accommodation is the way in which you are increasing the power of the eye. If you lose accommodation, then you lose the power of the eye. That is, your power of the eye is decreased. Power of the eye is decreased. So for these patients, what type of lens will you suggest? For these patients, again, you will give plus lens to increase the power of the eye. That is spherical lenses. That is convex lenses. For these patients, again, you will give plus lenses. So according to the age of the patient, you need to give the lenses to him. If the patient is 40 years, that is around the age of 40 years, he starts developing these symptoms, that is unable to read nearby objects because of loss of accommodation. At that time, you need to prescribe him glasses of +1 diopter. And then for each 5 years, you go on adding +5 diopters to it. +1 5 diopter. At 50 years, you give him 2 diopter lens. At 55, you give him 2.5 diopter lens. And at 60 years, you give him 3 diopter lens. After 60 years, you don't need to increase the power of the lens. You need to keep it as it is. If he becomes 90 years also, then also the error correction will be 3 diopter only. Till 3 diopter, you need to do error correction for this patient. This is about accommodation and presbyopia. And then there is a very small topic which is called as aphakia. Aphakia, as the name suggests, aphakia, that is the lens is itself not there. Lens is itself not there. The causes for which can be congenital. This is rare, but yes, this can be there. Congenital causes where the lens is only not formed, and they can be acquired. Acquired are mostly traumatic it can be post surgery. Now, what is the problem if the person has aphakia? Aphakia means the lens is absent, so the refractive medium is absent. So this person will have high hypermetropia. High hypermetropia. That is the problem of not having a lens. So now, what are the clinical features? Clinical features is high hypermetropia, blurring of vision, all those are there. There are specific signs because this is the eye, this was the lens, this was the iris. Okay. Now, because this lens not present now, the iris does not have any support. So there are various signs in this. I will tell one by one. So the lens is not there, so eye does not have any support posteriorly. So this iris appears to be trembling. That is iris iridodonosis. Iridodonosis. Because there is no lens, you are seeing the pupil. There is no lens. Everything appears full black. Full black. This is called as jet black pupil. Jet black pupil. And if the patient has developed aphakia after the surgery, you could also see some scar marks on his limbus hand. These are the signs. And retinoscopy, if you check for the refractive error, he will have very high hypermetropia. What is the correction you can give? Treatment, optical treatment, for he has decreased power of eye, so you should use convex lenses, that is increasing the power of eye. For this patient, you need to use very high convex lenses, that is up to 13 diopter power. Otherwise, you can use contact lens. Otherwise, you can do surgeries where you can place intraocular lens. This is about aphakia. So I'm done with my topics. Does anybody have any doubt? So I will revise it once again, these two topics in very briefly, and then if anybody has any doubt, you ask. Accommodation is the ability of the eye to see near objects. To see the near objects, the eye needs to increase its power. It can increase its power by increasing the curvature of the lens. How? By contracting the ciliary muscles. That is what accommodation. So accommodation has three components. It has ciliary muscle contraction, convergence of the eye, that is eye moves towards nose, and then constriction of the pupil. The loss of accommodation is called as presbyopia. This is seen in old age, where there is decrease in power of eye, because of which he is unable to read the nearby object. The correction is positive lenses, that is convex lenses. The correction at 40 years, you give +1 diopter. There, after that, for every 5 years, you increase 0.5 diopter till 60 years, where you will get 30 diopters. After that, you keep 33 diopters as it is. 3 diopters as it is. This is what is accommodation and presbyopia. And then aphakia. Aphakia is absence of lens. The absence of lens can be congenital, where there is lens is only not formed, or this can be acquired. This can be because of a trauma, or this can be because of surgery. Thus, clinical, the person has very high hypermetropia, so he has blurring of vision, all those things. And then signs, because of the absence of lens, iridodonosis, jet black pupil, very high hypermetropia. Treatment for this, optical and surgical, optical convex lenses, very high power convex lenses, and surgeries, intraocular lens placement. So this was about aphakia, accommodation reflex, astigmatism, myopia, hypermetropia. If we see the questions, we have covered almost all the questions. There's different hypermetropia, myopia, management of astigmatism, and refractive errors, hypermetropia, aphakia, last I told. Aphakic glass, this is left. This, if the glasses that I was talking about, that is high convex lenses, it has problems with using those very thick glasses. You see that afterwards. Okay, myopia, we did talk, myopia, astigmatism. Sturm's conoid, this is seen in astigmatism. This is a concept. This was asked only once, so I'm not discussing. Then presbyopia we saw. The surgeries, various surgeries for myopia, accommodation we saw. This also we saw. Emetropia, myopia, aphakia, LASIK, radial keratotomy we saw. Okay, all this we saw.